Hello, everybody. Welcome back. Today, we're going to go through childhood disorders in a quick and dirty fashion. Remember, for most of these, you need the bare outlines, you need the basic definitions. You don't really have to go in depth in the etiology or the pathology. So, just as a basic overview of infant development, remember the infant is from 0 to 12 months, so a year, and this is when you have your primitive reflexes, right? And then this is the beginning of socialization and object permanence, orientation, and speaking. Toddler is, remember, CRW. So this is when you start being able to draw, to stack, to climb. Their motor skills are developing even more. They're starting to become a little bit more independent, and then words, they're starting to speak and use sentences, almost sentences. So the preschool years, you can also remember them as the don't phase. So they don't want to do things, they say no a lot. But now they can draw some more, they can ride a trike, and they have a lot more confidence in being away from their parents as of now. They're also beginning to form little friendships and, starting to find their little playground dates and the other stuff. And of course, learning starts really ramping up during this age. So there's some people who try to teach their child all of the things in the toddler months, but they're not going to retain it as much nor have the interest until at least 3 to 5. These reflexes are interesting, but not the major reflexes that you want to at least know. The ones that you want to know are the palmar, the plantar, also known as the Binsky, the rooting, the moro or the startle, and the tonic neck reflex. This is a little bit rarer. These four you definitely do need to know. Okay, so the heavier topic, child abuse. We as physicians can't really do anything besides being very observant. So the physical abuse comes in the form of patterns of injury. So the child and their parents come back to the ER like every so often, but it's a regular interval, like every 3 months, every 6 months. You can expect them to come. The areas of injury tend to be hidden. So people can, people who abuse children will do it in places that they can hide with clothing. So when you're doing a well child exam and you are suspecting child abuse, roll up their sleeves, examine the inside of the elbow, the inside of the armpits for any signs of trauma, bruising, burns, cuts. You want to also pull up their pants, see anything in the inner thigh, around the hip area. So if you can, you want to examine them with the minimal amount of clothes and look for places where injuries can be hidden. Sexual abuse, of course, would be STIs, UTIs, genital, anal, and oral trauma. This should not ever be in a child, except for maybe the UTIs. UTIs are pretty common in kids, but it should never have organisms such as chlamydia in it or gonorrhea. So you want to do a urinalysis whenever they come in complaining of a UTI. Also, like I said, you got to look for the patterns. If they're coming in every month because of a UTI, of course, you want to suspect maybe this is a anatomical problem. They could have some kind of reflux. They can have some kind of, kidney infection. That's pretty rare, though. Unfortunately, UTIs from sexual abuse is more common. So always suspect. And the children will act very suggestively, and they will know a lot of sexual terms that is far beyond their age. So if a child, is 5 and comes up to you and talks about how they do the reverse cowgirl, you should be suspicious. Emotional abuse is just as bad as physical and sexual abuse. This manifests as the children being far, far too affectionate, far too friendly with strangers. And when they are by themselves, they turn to be emotionally labile and aggressive to other children and animals in particular. But then they'll turn around and act all sweet around an authority figure, an adult, right? So you want to ask if they have siblings, their siblings, if, they act one way with their siblings and another way with their parents. They also complain of vague somatic symptoms with no kind of explanation. So it's like, oh, my wrist hurts, but you don't really see anything wrong with the wrist. Nothing is showing up on the test. The physical exam is normal. So they could be trying to look for attention, or it just manifests as, a somatic symptom. Emotional abuse is one of the worst because it is very insidious. So it starts when they're younger, but then almost always causes a criteria for at least one psychiatric illness by the age of 21. So emotional abuse can be, not can be, it is usually associated with neglect. And then neglect is generally it's pretty easy to spot. Of course, there's the poor hygiene. So a child should not be crawling with lice, okay, kids get lice pretty often, but if it progresses to something like scabies, then you should be suspicious. They have poor education, but much lower than their levels should be. So a kid that is 10 who doesn't know how to read, that's suspicious. Malnutrition is a big one. This is the most common one. The kid comes in and is far, far too skinny, and then they act very lethargic. And of course, there's some impaired social skills, and emotional development is going to be stunted. So if you suspect, always call CPS, which is Child Protective Services. There is and there's really no harm in calling CPS, even on a suspicion. It's not going to backfire on you. You always should act on your instinct, because a lot of the time, child abusers know how to hide these things, and they know how to train the kids to kind of lie to us, the physicians, or anybody in the authority figures. So if you're suspicious, please, 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 just call CPS. It doesn't hurt. Okay, so childhood disorders are disorders that can only be diagnosed and labeled in childhood. So the first one is ADHD. We kind of all know that. The onset has to occur before 12, and it commonly coexists with the oppositional defiant disorder. ADHD is most commonly reported to the parents by the teachers, because the child isn't paying attention, they keep on fiddling, they're disturbing the class, and usually their school work takes a hit. And then you want to treat them with some kind of stimulant, such as methylphenidate. And the second line is atomoxetine, or some kind of alpha agonist, such as clonidine. So autism spectrum disorder is, we all know about it, so I'm not going to stay too long there. Just remember, it's a spectrum. Conduct disorder is going to be basically antisocial personality disorder before the age of 18. So this is a repetitive, pervasive pattern of behavior, and this is violating social norms such as stealing or basic rights of others, which is, bullying them, breaking and entering, things like that. And the only thing you can really do is treat with CBT. Disruptive mood dysregulation order is diagnosed in children before the age of 10. And this is a tantrum on level 11. It is very, very severe, and it's very out of proportion to the situation. So a child throwing a tantrum will just kind of throw themselves to the floor and just cry and whatnot. But disruptive mood dysregulation is they're going to like start hitting other people. They're going to start destroying property. Like it's beyond just like laying on the ground and crying. But beyond that, the child is constantly angry and irritable between episodes. So this kid is never happy. They're always angry and they're always in a mood. The things we can do is we can treat with cognitive behavioral therapy, some kind of stimulants such as methylphenidate, and in pretty severe cases, we can use antipsychotics. Intermittent explosive disorder is similar, but it is diagnosed before or past the age of 6, and it is once again like a tantrum that is out proportion to whatever provoked. Sorry, I don't think provocated is the word. The outburst, and this kid is just very aggressive. They're unable to control their temper. These are the temper tantrums. However, in comparison to the previous disease or disorder, the child will not necessarily lash out at other. They have a big old screaming match on the ground, but in between episodes, they're a happy, normal child, So you want to treat them with psychotherapy and an SSRI. So there is a difference in treatment here. Oppositional defiant disorder, remember, it coexists with ADHD. This is a pattern of anger, irritability, and they are argumentative and defiant towards authority figures, and this pattern of behavior has to last more than 6 months. So this can occur because of a variety of reasons. It could be because of the ADHD. They think that they're being targeted for just being themselves. It can be due to a learning disability. They think that, people might make fun of them for being dyslexic, so they lash out first. And you want to treat this with CBT. Selective mutism is a form of anxiety, and it starts before the age of 5. So it lasts before a month, but time can vary. The neat thing is language and speech is typically not impaired. So to treat it, you treat with behavioral, family, and play therapy, and in severe cases, you want to treat it with an SSRI. So in order to kind of target the mutism, you want to actually address the anxiety. Separation anxiety is the overwhelming fear of separation lasting more than 4 weeks. This doesn't have to be a disorder until it's far past the age of normal age of school and independence. Then it would just be anxiety. Separation anxiety is pretty normal, especially in the pre-K age, but the child generally will grow out of it. So you want to treat them with CBT, family, and play therapy. The specific learning disorders, there's a variety. The most well-known is, of course, dyslexia. But then there's some other learning disorders that is like difficulties in math or kind of like language comprehension. And of course, in order to treat those, you have to put the child in certain programs to help with those skills. And Tourette's syndrome is something that is getting very popular nowadays due to TikTok, and not in a good way, because Tourette's syndrome is a very serious and very distressing disorder. So it's good that they're getting exposure, but bad because people think it's kind of cool to copy and pretend that they have Tourette's. But as a physician, let's kind of dive into the criteria to filter out the real versus the false. So in true Tourette's, these symptoms start before age 18, and they are sudden, recurrent, non-rhythmic, motor, and vocal tics, and they last more than 12 months. So the most common one is, they're just blurting out curse words. That's not actually very common. The most common are the motor tics, motor or vocal tics. So it's like a weird grimace or a head tilt or a smacking of the lips. So those will occur regardless of the situation. So that means that this can occur even when they're not stressed, like it's just happening. These are usually associated with OCD and ADHD. And the way you can kind of identify it from somebody who is faking is you want to ask the family, see if there's a history of this. If it starts suddenly, like after the age of 18, say this person is 21 and it started in like 2020, that's not really common. It could be fake, could not be fake, but in general, for all these patients, these are distressing tics. They're like, I don't know why I keep doing this. I don't want to keep doing this. It's not fun. It's not popular, and it does interfere with daily life. So it would be somebody who can't stop, like, let's say, like doing that, and then they're starting to not be able to land interviews because they keep in the middle of each sentence, and the interviewer might see that as like rude or something, so they're distressed because this interferes with daily life. So you want to treat them with some kind of psychoeducation, CBT, and for severe tics we do give tetrabenazine or an antipsychotic or alpha 2 agonist. Okay, so that's it for now. Thank you for your attention, and I'll see you next time.